Welcome to this explainer. I want you to close your eyes for just a second and put yourself directly into the shoes of an attending physician. You're clocking in for a high-stakes hospital shift, and today we're diving into the incredibly complex, often kind of counterintuitive world of cardiovascular pharmacology. The decisions you're going to make today will quite literally mean the difference between saving a life and causing catastrophic harm. You ready? Let's get into it. So the philosophical hook of our entire shift really boils down to one question. When do you escalate, and when do you just do nothing? It's the absolute core tension of clinical practice, right? Having that critical judgment to choose between acting aggressively and waiting patiently. As we'll see today, doing something isn't always doing the right thing. Sometimes the absolute most heroic action you can take is having the restraint to just step back. All right, here is our rounding list for today. 1. Navigating outpatient hypertension. 2. Managing drug side effects. 3. Acute ischemia and arrhythmias. And 4. Hypertensive urgency versus emergency.
Starting off with Section 1, Navigating Outpatient Hypertension, Striking the Balance in Chronic Care.
Okay, let's kick off this shift in the outpatient clinic. We've got two vastly different presentations waiting for us that are really going to test our restraint. In room 1, we have a patient with stage 2 hypertension. They're already on lisinopril, but their blood pressure has been stuck in the 150s over 90s for 9 months. They desperately need dual therapy. We literally have to step in and add a calcium channel blocker like amlodipine. Why? Well, because we have to prevent silent end organ damage, like a stroke or left ventricular hypertrophy. Now look at the patient in room 2. They are totally well controlled on hydrochlorothiazide, keeping that pressure under 140 over 90. Adding another medication here, like nifedipine or more lisinopril, would just be a terrible idea. Overtreating here unnecessarily risks hypotension, dizziness, you name it. For them, routine surveillance is the only correct move. The bottom line for this first case is this. Proactive medicine means addressing that persistent elevation before the silent damage even happens. The guidelines tell us patients with uncontrolled stage 2 hypertension, despite adherence to monotherapy, should be treated with dual antihypertensive therapy. When monotherapy fails over a reasonable trial, you don't just wait around, you escalate. It's a perfect example of when clinical inertia is actually a huge risk to your patient. Moving on to Section 2, Managing Drug Side Effects, Understanding the Body's Compensation. Let's head over to room 3. Our next clinic patient is experiencing mild palpitations while taking nifedipine for Raynaud's phenomenon. Let's actually walk step by step through the physiological chain reaction happening under the hood here. Nifedipine is a dihydropyridine calcium channel blocker, meaning it dilates peripheral arterioles to help stop the vasospasms of Raynaud's. But, when you dilate arterioles, systemic blood pressure drops. Your body senses this drop via baroreceptors, panics a little bit, and cranks up the sympathetic tone to maintain perfusion. And the result of all that? Reflex tachycardia. The heart beats faster to compensate. What this proves is that the patient's palpitations and even that mild peripheral edema she might have are completely predictable, non-threatening side effects. It's definitely not a dangerous new arrhythmia. Since this is just a normal physiological reflex, reassurance is absolutely your best clinical choice. You might be tempted to fix that fast heart rate, but you've got to resist that urge. Adding a beta blocker like metoprolol is incredibly harmful here. It would allow unopposed alpha-1 construction, instantly making her painful Raynaud's vasospasms worse. And what if you switched her to prazosin? Actually, scratch that. Prazosin is notorious for causing orthostatic hypotension, which is super risky for a patient who is already experiencing reflex tachycardia. Here's the anchor for this scenario. Reflex tachycardia due to arteriolar vasodilation is a known side effect of nifedipine and typically does not require intervention unless severe. Suppressing a totally predictable physiological effect with more drugs just introduces unnecessary risk. If the drug is working for the Raynaud's and the side effects are mild, the best prescription you can write is just talking to your patient and reassuring them. All right, Section 3, Acute ischemia and arrhythmias, the high-stakes ICU shift. Okay, the tension is definitely escalating now. We're stepping into the ICU to manage an acute inferior wall myocardial infarction presenting with hypotension. This presentation perfectly dictates our choice of vasopressor. An inferior wall MI often involves the right ventricle, which impairs preload and tanks the pressure. We have to raise that pressure to perfuse the organs, but the heart is already absolutely starving for oxygen. If we use dobutamine or epinephrine, their beta receptor activity is going to force the heart to beat faster and harder. That fatally increases myocardial oxygen demand and just worsens the ischemia. Phenylephrine, on the other hand, is a selective alpha-1 agonist. It clamps down on the blood vessels, increasing vascular resistance and blood pressure with zero direct stimulation to the heart rate. In this specific scenario, it is literally the only correct answer.
Suddenly, alarms start blaring in the very next ICU bed over. We've got a patient experiencing this exact life-threatening rhythm, monomorphic ventricular tachycardia. It is a terrifying rhythm to see pop up on the monitor. But when you rush into the room, there's a huge twist. The patient is sitting up, talking to you, and is completely hemodynamically stable.
So here's the exact protocol for this highly specific scenario. Because the patient is stable and perfusing their brain, you actually have time for pharmacology. You administer intravenous amiodarone immediately. Amiodarone safely prolongs the action potential duration to terminate the rhythm. Now, what shouldn't you do? Do not grab the paddles and defibrillate. Shocking a conscious, stable patient causes completely unnecessary pain and harm. You gotta save the electricity for patients who deteriorate or go pulseless. And whatever you do, avoid verapamil. Giving a calcium channel blocker like verapamil for wide complex tachycardia can depress myocardial contractility so severely that you precipitate catastrophic cardiac decompensation. No way we want that.
So here's your satisfying bottom line for critical arrhythmias. Stable monomorphic ventricular tachycardia should be treated with intravenous amiodarone. Electrical interventions are reserved for patients who deteriorate. Treat the patient, not just the monitor. If they're stable, use the medicine. If they're unstable, use the electricity. Section 4. Hypertensive urgency versus emergency. The ultimate test of clinical judgment. For the climax of our shift, we are sprinting down to the ER to see two patients with identically terrifying blood pressures. We're talking well over 180 over 120. But the definitive life-saving difference between these two states hinges entirely on one thing: the presence of acute end organ damage. It is absolutely not about the blood pressure reading alone. The patient presenting with urgency has no acute organ damage, but the patient presenting with emergency, they're confused, showing focal deficits, maybe they even have retinal hemorrhages, which means their brain is actively taking damage. Let's manage our urgency patient first. Since their hypertension is chronic, their body's autoregulatory mechanisms have physically shifted to handle these much higher pressures. If you panic and rapidly drop their blood pressure with IV meds or unpredictable sublingual nifedipine, you will cause devastating cerebral or renal ischemia. You will literally starve their brain of blood. So what's the correct approach? Gradual reduction over hours to days using oral medications like amlodipine. You send them home with really close outpatient follow-up. Conversely, the emergency patient needs you to act right now. Their brain is already under attack. That's hypertensive encephalopathy. We admit them to the ICU and start IV sodium nitroprusside immediately. Nitroprusside is brilliant for this. It releases nitric oxide for rapid, highly titratable vasodilation. Because it works so incredibly fast and clears so fast, you can bring the pressure down precisely, minute to minute, stopping the brain damage without overcorrecting and accidentally causing a stroke. And that brings us to the primary lesson of the emergency department. The distinction between urgency and emergency hinges on the presence of end organ damage, not just the BP value. The numbers alone do not dictate your treatment plan. The patient's actual physiological reality does. Section 5. The big finish. Proactive versus reactive medicine. And just like that, our shift is over. From the clinic all the way to the ICU and the ER, we've seen that mastering these clinical crossroads requires truly understanding the why behind the guidelines. Whether it's having the courage to proactively start dual therapy, the restraint to reassure a patient through a harmless side effect, or the precision to choose the exact right pressor, it all comes down to your clinical judgment. So take this knowledge with you. How are you going to handle the pressure when you're the one making the call?